This is Digital Pathology Today. Now, here's your host, Dr. Joseph Anderson.
Welcome to Digital Pathology Today. I'm Joe Anderson. Our guest today is Dr. Raj Singh, professor of Dermatology and Pathology at Northwell Health. He directs the Dermatopathology section and is the associate chair of Digital Pathology. He is, of course, the founder of PathPresenter, an online digital platform having over 125,000 users across 170 countries worldwide, used in academic departments, private pathology groups, and organizations in the U.S. and across the world. Today we're going to learn about what exactly is PathPresenter, how was it developed, what was the unmet need or opportunity that arose to facilitate its creation and adoption. It seems like one of the features of digital pathology is to facilitate increased connectivity among and between pathologists, which is helping to democratize access to care and makes the benefits of surgical pathology review and expertise available to underserved populations worldwide, but also makes this expertise in diagnostics available to pathologists across the country and across the world. There's more to pathology workflows than simply signing out a case or issuing a diagnosis. Of course, it varies according to practice environment, but pathologists have to do other things, such as present cases at tumor board or multidisciplinary conferences. And of course, there's pathology education. How is pathology education going to change with this increased connectivity and on-demand access to digitally archived images?
This episode of Digital Pathology Today has been brought to you in part by JAV Advisors. With over 16 years' experience, JAV Advisors focuses on business and management consulting for digital pathology and artificial intelligence in deployment within histology, pathology, and cytology laboratories throughout the world. Call 213-258-6268 for more information. JAV Advisors.
Dr. Raj Singh, welcome to the podcast.
Thanks, Joe. Thanks for the opportunity.
So tell us a little bit about yourself and your background in digital pathology and your experiences that led us to this point.
Yeah, it's quite an interesting journey. So I work as a pathologist currently at Northwell as the chair of digital pathology, vice chair of digital pathology, and also as the director of DermPath. Before that, I used to work at Mount Sinai for almost 10 years, and before that at the University of Pittsburgh. And anybody who's been working at the University of Pittsburgh, UPMC, definitely knows what is digital pathology because they were one of the pioneers in this space. So when I was working there, we already had some scanners that were put there by different companies for testing, and we used to scan some slides. And when we were using those slides, it was very interesting to see like how it made it easy for us to do the teaching and like getting a second opinion from somebody when you're using a digital slide. I started collecting a lot of digital slides for teaching, not only from the good cases that we saw, but also from other places that had digital scanning at that time. And by 2016, I had a very good collection of slides that we were using for teaching. The question was arising that when the residents and when the trainees were at different places, how do you give them access to these slides without them traveling all the way from, let's say, around a 20-mile away hospital to come for a 1-hour teaching session to the main hospital. And so the idea came up that if we could put these slides on the cloud, it would be good for us to then just share our computer screen and let them see the slides from the cloud. And that is where PathPresenter started off, like just as a need of the hour that we wanted to teach trainees and residents that were 40 miles away.
Okay, yeah, I think that's interesting as we're diving into the many use cases or applications of digital pathology. I mean, there's certainly much more than one, right? People think of pathology as rendering a diagnosis, but there's so many more applications and actual use cases for this. And I think what often may get neglected is education, pathology education, resident education, because I think many of us can think back to the old days, or even in your personal experience, you see a great case and you say, oh, this is really great. I'd like to look at this again sometime, or somebody else might appreciate this. And then you put it in your little personal collection, maybe a shoebox or a slide folder, and you stick it on your shelf. And then maybe no one would ever look at it again. So I think there's so many advantages to digitizing these things immediately that can, make them available. And then, just bridging the distance, right? Does it even make sense to drive 40 minutes each way for a 1 hour session? So I think that's a very powerful and compelling use case. So do you think you were alone in this, or did other people really see a focus in education starting out?
So this was where in 2000, the idea came up at UPMC, but then I moved on to Sinai, and then Sinai actually had 4 different hospitals, and there was always this issue of how do you train the residents there. But when we wanted to put the slides on the cloud, and we actually approached a few companies that were already in the space, and we asked them, like, could you help us out, put these slides on the cloud and help us to use them in a much better and effective way, and let other people also use them. So somebody in South Africa wants to see the same slides and use them. If they are on the cloud, they would be able to use them. But we didn't get any good support from any of the existing companies at that time, and because nobody helped us out, then I said, let me build this on my own, and that is where we then started getting help from a few engineers that we knew as friends, and they helped me build this backend software that would allow us to upload the slides on the cloud, got the viewer in, and then those slides could be viewed. So it was a very simple basic application that would allow anybody to upload the slide on the cloud and then view them from anywhere, and it turned out to be a very, very powerful tool in 2016.
Yeah, I like that. So you did it yourself out of necessity. And now, are you finding that obviously there's an economic case when you sign out cases and you can bill CPT codes 88305, 88307, 88342, right? There's obvious money changing hands in exchange for services, but there's so many other things we do in pathology that don't get reimbursed directly per se, such as training residents or presenting at tumor board or, asking your friend across the country, oh, can you look at this difficult case? So have you found that the economic barriers or the practical considerations have been stumbling blocks in making this work?
It is a very difficult place to be in when you're trying to do all this with very little support. There was the whole thing suddenly changed in 2017 when PathPresenter was already being used by a lot of people for seeing these cases that we had put on the cloud for education. But in 2017, when the Philips scanner got the FDA approval, that was the first, I think, turning point for digital pathology. There are a couple of other turning points that happened after that, but the first turning point for digital pathology was when Philips got the FDA approval, and now all the institutions suddenly started thinking about buying scanners and installing the digital pathology ecosystem to be able to view the slides or to help make a diagnosis using digital slides. And because PathPresenter was already up and running at that time, a lot of people who started buying those scanners also became very interested, because if you look at an institution, when they buy a scanner and when they buy all the equipment, it's an investment of almost $1 million to $10 million. And they will put up all this equipment, they will buy the storage, they will scan the slide, and once the slide is scanned and they have looked at it for a diagnosis, after that there was nothing available to utilize the slide for education. Like, how do I use this slide how do I integrate this slide into a PowerPoint presentation? How do I integrate this slide into a test module? How do I integrate this slide into a discussion module? And nothing of that sort was available. Yes, you put in the millions of dollars, but the slides were of no use unless you had the tools that would allow you to use that slide in a much more effective way if you want to use it for anything else besides making a diagnosis.
Yeah, so there certainly was a clear unmet need, or several unmet needs, which kind of necessitated you folks to build this. Now, before we dive into exactly, what is PathPresenter exactly and how, and specifically how you developed it, one more thing about education, which I just came to my mind as we were talking, is that it seems to be almost a direct opposite use case in some sense of actual daily practice, where in education, the focus is on, well, obviously something is clearly wrong on this slide or this sample, and there's, some process, and now your task is to show us how smart and how clever you are and come up with your differential diagnosis to make the diagnosis and move the case along, versus in actual practice, what we do is a lot of looking for the needle in the haystack, where much of what we see is normal. So we're trying to find isolated tumor clusters in a lymph node or 17 lymph nodes, right? It can be very tedious, and the goal isn't to show how smart you are, how clever you are, but rather to see what is your attention to detail and how focused you can be. Looking at a prostate biopsy, are you going to find 2 or 3 abnormal glands? Are you going to find the DCIS or the invasive lobular carcinoma that's lurking in a breast biopsy that seems completely normal? So it seems to me kind of the tasks and the functions are, just barely related or maybe even opposite to each other.
And I think that's where you hit the second turning point. So the first turning point was the scanning of the slide, of the scanner being FDA approved. And then the second turning point in 2018, let's say around 2018, AI has been there. AI and machine learning has been there from in the 1960s actually. People talk about AI and machine learning in the 60s, 70s, 80s, but it never took off. And the only reason it never took off was because there were 2 or 3 things that, one, the storage was very expensive on the cloud. But more importantly, the computers were not as powerful as the computers of today. And thirdly, the tools that the algorithms that people can use to build these models were not as powerful as they are currently today actually. So in 2018 and 19, all these factors came together where cloud storage became quite cheap. The computers became very, very powerful. Now, the computer that my son takes to college is much more powerful than a supercomputer of 2006. So even what they have in college, the teenagers have in the schools and colleges is more powerful basically. So the computers became very powerful. And third, the algorithms and all the tensor flows and everything started becoming available because Google, Facebook, Amazon all started using AI not for pathology but for other things. They wanted to use AI to get more people to upload images onto Facebook or for Amazon to find the right customers. So the AI became very, very powerful, and that I think was the second turning point, where you already have a digital slide that many institutions were now starting to accumulate. So that data was there. And then suddenly all these AI tools becoming very, very powerful. And then what you said, people thinking can this now be achieved where the pathologist job can become a little bit more simpler if the machine can help find that lymph metastasis in 20 different, when I was a fellow at MD Anderson, we used to go through 2 big trays of just lymph node biopsies to find that one single cell of a metastatic melanoma. So with this powerful AI learning more tools becoming available for researchers, and then the data becoming available, all these questions started coming up, now can these two come together and produce tools that not only would help the pathologist in making the diagnosis, that is just one small part of the entire equation. But the more powerful thing that people started to realize was, you have the data, and this data is not only the digital slide. So now the digital slide is an image, but that is one part of the data. With that image, now you have a lot of associated metadata, did the patient smoke, what kind of underlying molecular changes did the patient have, what treatment was given to the patient, did that patient respond to that treatment. So if you start combining this metadata with that image, so just for an example, if I have 500 cases of melanoma, and I could separate those cases out, that these were 250 cases that were given some specific treatment, and these were 250 patients that were given another treatment. And if you look at the retrospective data, the patients that received treatment A fared much better than the patients that were given treatment B. So now that becomes like a training module that can be used to train a model that would be able to predict why these 250 patients did better and why these 250 patients did not do better. And those models, now you're not only helping the pathologist in making a diagnosis, now you are helping the patient in predicting what his prognosis is, what his or her prognosis is, what treatment is going to be effective. So you're helping the patient, you're helping the oncologist, and that is where the whole power of digital pathology is basically.
Yes, yes, excellent. I think we've certainly been the beneficiaries of all these improvements and enhancements in technology, such as artificial intelligence and image analysis. But I think that brings up a really interesting point. So, what exactly is our task? What is the highest and best use for digital pathology? Because I think it's, people on the outside looking in, may have a different perspective from what we as pathologists identify as what we're going to be able to do with these new tools. I think most would agree pathologists perform very, very well right now in terms of, and they have for hundreds of years, at least 100 years since we've been using the microscope, in terms of being accurate in making diagnoses and conveying that information to doctors and patients. So I think, so how are we going to improve? Is it more like, I think, streamlining our workflows to enable us to have higher throughput, and then to, as you suggested, add metadata and mine into images deeper for features that would not readily be available or reproducible by the human eye, so we can add so much more value and convey so much more information than we were able to before.
And the important part for the pathologist in that role is, if you're going to produce any kind of algorithm that can predict either a prognosis or a treatment for the patient, which makes the whole thing very powerful, is that algorithm, if it is a black box algorithm, it would be very difficult to get past the FDA or use it for in real, like it is good for publishing a paper. But if you want to take it to the real world and make it available for every oncologist or every patient around the world, there is a lot of it. You have to be able to explain why these features are there, and the best person to do that explanation is a person who's been seeing these cases for so many years, and they can see like if they look at 10 to 100 cases of one pattern and another 100 cases of another pattern, the person who can explain it the best would be the pathologist.
That's a very interesting point, because I think that's in many ways been a stumbling block, in that the expertise was kind of cornered by one person or a group of people. And the reason why the diagnosis is what it was is because I say that's what it is from on high. And the reason I say that's what it is because I've reviewed so many cases and I'm the world's expert, or something along those lines. I think it's ultimately, the diagnosis is an opinion, a well-informed opinion, hopefully that there will be inter-observer variability among pathologists. But as we scale and we introduce computational tools and artificial intelligence, is that going to be a stumbling block, that it's a black box and people don't trust it? And is regulation going to be a hurdle, or are we going to be able to have transparency and be able to explain how we develop these new tools?
The FDA is definitely big on transparency. Like we have been working closely with some of the groups in the FDA that are using the PathPresenter platform for collection of data. So we have been working closely with them, and what we have learned from the multiple interactions with them is the FDA is currently opening up to allow a little bit of black box like data, but not like a complete black box basically. So they would want at least some kind of partial explanation that why these patients will fare better or why this treatment is going to work better. So we definitely need the retrospective data and the input from a pathologist to explain like what are the differences that we are looking at that will help, that are predicting this prognostic thing that you're talking about, or the treatment that you're talking about. So that is the reason I think this is very, very exciting for any pathologist who is now part of this ecosystem. Is this is the time where they can come out from the basement, or as a player that is not mainly involved in the treatment of the patient. All they do is like put in a report, and nobody then ever talks to the pathologist.
Right. I'm certainly with you there, that this could be the start of a new golden age, or really the opportunity to add even more value and create even more visibility for the profession, because I think
definitely this is the time.
Yeah.
And that is the reason like I always urge pathologists that don't like close your eyes, or like you say like those three monkeys, that you see no evil, hear no evil, and speak no evil. So like you cannot do that right now. Like you cannot close your eyes, shut your ears, and not speak about it. As pathologists, like we should be taking like charge of this whole thing, get used to digital pathology, get used to a little bit of computational pathology so that we can then lead the way. Like, yes, we don't need to sit and do the coding, but definitely we could lead the way of where this whole thing is going and how the pathologist's role is going to change and in the management of the patient. And there are so many studies that have shown that like 70% of all decisions that clinicians take are based on the pathology department assessment. So what comes out of the pathology department? It could be a blood test, it could be a histopathology report, it could be a molecular test. Everything that is coming out of the pathology department is forming the basis of every decision the clinician is taking for the treatment of the patient.
This episode of Digital Pathology Today has been brought to you in part by DJT Solutions, your single source for all your digital pathology requirements, from consultation services to system requirements, including installation, training, and life cycle support. Since 1995, DJT Solutions, we are your best choice for your best results.
We've always been there, maybe in the basement. And like you said, I think it's the College of American Pathologists has gathered significant data on this, and that 70 to 80% of treatment decisions are based on laboratory results as well as anatomic pathology. So is this going to be a golden age, and what's it going to look like? Are we going to be able to move away from the microscope and the computer and take more of a central role in guiding therapy and advising doctors and patients?
That is the hope. I'm really looking forward to that kind of involvement of the pathologist with the team that is involved in treating the patient, and this is the opportunity that can do that. So as long as pathologists understand that this is the hope and the opportunity and the time to really now take charge and make sure that they do not let digital pathology to be controlled by other people, and that is why I think PathPresenter has become a very important component of the digital pathology space. Because one other thing, Joe, the other thing that we were always struggling with is we see a lot of papers. I get a lot of paper as editors in multiple different journals. We get a lot of papers to review, and there's so many papers that are coming out that people are working on different kinds of tools, either for prostate cancer or breast cancer or colon cancer, where they are using data from their local hospital. So some paper might come out of Sloan, some paper might come out of National Cancer Center in Japan, or a big hospital in South Africa, where they are building these very spectacular tools that they talk about that can differentiate, let's say, between a melanoma that has a BRAF mutation versus a c-KIT mutation, or a melanoma that fared better, or not only a melanoma. Let's talk about lung cancer and prostate, that is much more common basically in the world outside of the US and Australia, where people are doing these spectacular studies. But one thing that we struggle with is you are using data from a local hospital. You might be using data from Brigham, you might be using data from MD Anderson or a big cancer hospital in South America, and you're building these tools. But will this tool now work in India? Will this tool now work in Malaysia? Because you have never either trained or tested this tool that you have built out of data that is coming from these countries basically. So the important thing that I really want people to understand is, if you really want to build any kind of AI tool or machine learning tool that is going to help your patient or your oncologist, that tool definitely needs a training set or a testing set that is diverse. It shouldn't be coming from one institution. You have to start getting used, you have to find a way where you can get a diverse set of data that you will not only use for training your tool but also for testing your tool. And that is one thing that is lacking in a big way. So your tool is going to be useful for a publication, but will it work in the real world is not at all clear unless you are going to test and train it using a diverse data set that is coming from multiple places around the world.
Yeah, I completely agree. You said a lot there. I think one thing that has perhaps held us back or hindered us is a lack of consistent or uniform approach and really understanding how to appropriately do discovery, development, and validation. And like you said, it has to be done in a rigorous way for this to all move forward. And I think it's been done in pharma, and it's been done, at these large companies, developing these molecular classifiers. But there are principles involved that, studies or tools need to be developed in one set of patients and then validated in rigorous studies. And then, of course, there's levels of evidence, and the highest levels of evidence are generated in multi-center studies where you can control or take into account for differences in patient populations and laboratory techniques and so on and so forth. And you have a pre-specified plan of analysis. And so there's level 1 evidence, which is multi-center prospective randomized trials done in multiple studies, which is going to be your highest levels of evidence. So hopefully we're going to be able to follow that well-worn path to really bring these tools into reality. And then you said a few other things too. So one thing I kind of share your concern is this going to slip away from us as pathologists? And I say that, and I'm quite serious, and people look at me like I have two heads or I'm crazy, because it's so obvious that this is pathology. But my concern is, as it becomes digitized or it just turns into data, right? H&E images turn into pixels and data, is that what is going to be the role in the pathologist in all of this, right? How important is that foundational training in morphology, in, developing tools, and then, being the expert, as much of this becomes automated or replaced by artificial intelligence? What's the role of the anatomic pathologist going to be?
That is another question that you will hear very often. Pathologists are quite fearful about all the changes that are happening in the digital pathology space, because they keep hearing about all these different kind of AI and machine learning tools that the world is currently really focused on, that will help in diagnosis, that will help in prognostication, and they worry that will I still have my job basically, or will it be taken over by the machine, or will it be taken over by some automated decision making systems? And what we have seen, this is not the first time that this fear has come. 20 or 30 years ago, when immunohistochemistry was brought into pathology, people were saying, now you don't need the pathologist. You do a melon A, you can make a diagnosis of a melanoma. You do a CD34 and you can make a diagnosis of a dermatofibrosarcoma protuberans. So you don't need the pathologist to now make a diagnosis, and that fear was there when immunohistochemistry came in. But it didn't do that. The pathologist's job became much more important because there were so many different tumors that would stain with the melon A or that would stain with the CD34, that it was the job of the pathologist became even more important, that they have to go and interpret, is this the real tumor or is it something that is falsely staining basically. So it became a more important and a more critical role, and the similar thing is going to happen with all these AI and machine learning tools in in pathology. There will be tools, they will tell you that this could be cancer or this could be benign, but in the end the pathologist will again have to certify that. They will have to come in and look at the case. They will have to look at the case and certify, yes, what the machine is saying is right. Otherwise it is not going to work. And so the role of the pathologist is going to become even more important now when you are going to use all these different kind of tools like it happened in immunohistochemistry.
Okay, yeah, that's encouraging. I actually try to explain it in the same way to people, that if anything, the role of the pathologist is going to become even more important. But also kind of I worry in the back of my mind, are we going to become the victims of our own success? And kind of what I see commercially is this stuff being potentially rebranded, especially when you introduce molecular and the ability to multiplex and add in computational pathology, right? You see companies, they're calling it something else now, right? It's kind of what we as pathologists have been fantasizing about over the last 10 to 20 years, right? Like someday we'll be able to multiplex, we'll use fluorophores, we'll use multiple antibodies for IHC, and the machine will be able to look at it, and it's just going to take us to the next level. But now I see it being rebranded as things like spatial genomics, tumor profiling, and that sort of thing. So how big of a concern is that?
I don't think it, like, if you are a very good pathologist, like you and if you just sit back and think about what you do every day. I'm a dermatopathologist, so I look at skin cases every day. If you are a lung pathologist, you are looking at a lung tumor almost every day. Now, if you just sit back and think at the variation that you see in like 2 slides or 2 patients, yes, we are calling them all melanomas, or we're calling them all lung cancers, or we're calling them prostate cancer, but there is so much variation in even like 2 slides when you look at 2 patients one after the other. For that variation is very difficult for machines to like interpret unless they understand like what is the underlying, not only the pathology but the pathophysiology of the whole thing. And yes, machines will be able to like say that this is a probability that this is a melanoma or this is a colon cancer slide, but beyond that it is only always going to be a probability. It will never be 100% accurate thing, because as pathologists we know there's so much variation. Like as from a patient perspective, I have melanoma, I have colon cancer, so that is all I know basically. But when as a pathologist, when you're looking at those slides, you know that even if you look at any the colon cancer cases, basically there's so much variation. Like there are some that have a lot of lymphocytic infiltration, there are some that do not have any lymphocytic infiltration. There's so much different variation in all the different cancers that the human body has to endure, that it is the pathologist's role will never, if as a pathologist you think about all the cases that you look at every day, then you shouldn't fear that this is going to go away, and it would be actually more important for you to be there when the machine is trying to differentiate these 2 cases, because you have to certify and also make sure that whatever is coming out is right and is truly going to help the patient, because that is what we all came into pathology for, to help the patient be treated in a much better way.
Absolutely, help the patient be treated in a much better way. So before we wrap up here, let's talk about the future of H&E, because I think a lot of this kind of hinges or revolves around H&E. Are we going to see perhaps a second renaissance or a golden age in H&E in terms of us being able to extract more information and features, albeit maybe from data mining or artificial intelligence and so forth? So is H&E somehow going to become even more important and allow us to add even more value? And then what is the future of tissue-based molecular going to be? Is that going to become somehow less important as we're able to predict the molecular features or phenotypes based on H&E morphology?
None of this is going to become less important. Like every thing is going, whatever can help the patient, even like if it helps the patient in a minimal way, is like, for that one patient that it helps, it is like 100% thing. So if you look at your first question, so is the H&E going to be much more important right now? What I feel is now with the people will be able to make, with the help of artificial intelligence and machine learning, and using them on the H&E slide, you will be able to now catch early tumors, like, because if the machine can help you, like say that the probability of this lesion being atypical, if you look at a bladder lesion, and if you look at the lesions that are like they are within the mucosa, intramucosal lesions, those are very difficult to interpret many times, like because is it reactive or is it like a real in situ lesion? So and the easiest way like the machine could help is like if they could average out the nuclear size and tell you that this is the variation in the nuclear size throughout the lesion, and if that can be correlated with a dysplasia, or that can be correlated with a in situ lesion, that would definitely help the pathologist using that H&E slide to make a much earlier diagnosis, rather than like allowing the patient to go through like multiple biopsies before they can make the diagnosis. And an early diagnosis is always a very helpful thing, because then the treatment can be initiated in a much earlier period, and the chances of treatment for any kind of cancer, the earlier it is done, the better chances for the patient that this will not progress and it will be clamped or cut out in the initial phases and will not be allowed to spread to either the mucosa or to the lymph nodes. So I think the HNE is going to become much more powerful than before, because now it has a lot of other supporting tools that will be used on the HNE slide to make a much better and informed decision for the patient, not only in cases of diagnosis but also in prognostication and predicting of the kind of treatment that would be most useful for the patient. And the second part is the underlying molecular changes. I think we will be able to find much more molecular changes. So when we talk about personalized medicine, it is about finding the underlying right molecular change for which a companion diagnostic drug might be available. And if you combine the AI and machine learning tool with the work that can be done on the digital slide and then with the underlying molecular changes, and you put all of them together, you might be able to find much more specific treatment for every patient. So all this in combination is actually going to make the pathologist much more powerful if they really want to take up that role and help the patient and the oncologist to treat the patient, to get an earlier diagnosis and also predict which is the best treatment, rather than just giving them randomized treatment that this is a treatment that might help you, that might not help you. Using the HNE slide, the artificial intelligence and the molecular changes, you might be able to predict a much more specific diagnosis for it, not only diagnosis, a much more specific treatment for that patient.
I think that's a nice message. Let's use all the tools in our arsenal so we can give doctors and patients the most complete information to help guide their treatment. So Dr. Raj Singh, thank you so much for being with us. So before we wrap up, just tell us what excites you now, and how do you see the field evolving in the next 10 years or so?
Like, this is, for me, this has been this has been a very exciting journey, because we started building all these different workflows that pathology departments, private pathology groups, even like academic researchers, pharma companies can use to extract the maximum information that they can from the digital slide. So we are building platforms where people can come. So there's a platform that we built called ai.pathpresenter.net. So although we call it AI, there is no AI done on that platform. All we are doing is we are using our connections as pathologists to get more data on that platform, so that people can find the diverse data sets. So we are not building any AI or machine learning. That is being done by so many other companies, and they are much better than us in the coding part than as a pathologist. But as a pathologist, we can get access to a lot of data because we know other pathologists and other academic departments around the world. So using those connections, we are trying to get all this different data sets onto a single platform, so that people can then come and train and test their algorithms that they are building on these platforms. The PathPresenter publication platform is now a very robust platform that allows integration of digital slides into ebooks. That makes the ebook very, very powerful, because then when the person is looking at the digital slide in that ebook, and with the annotation that the author has already put on the digital slide, it makes it like you are teaching somebody on a multi-edit scope, and that scope is on the cloud with like millions of heads. So when I write these books with digital slides and annotate them, when people look at these annotations in Japan, it is like I am pointing out that feature to them while sitting in my office in New York. So I'm like teaching that person in Japan, showing them the digital slide and pointing out the feature to them. So it's a very exciting time where all these digital slides and tools can be used for helping people get educated wherever they are in the world, helping patients get the best treatment wherever they are in the world, and making the best use of the pathologist, the strength of the pathology department, and helping the patient and the oncologist everywhere in the world.
Well, our guest has been Dr. Raj Singh from PathPresenter and Northwell Health. We'll see you next time on Digital Pathology Today.
Thank you very much, Joe, for the opportunity.
This has been Digital Pathology Today. Please be sure to subscribe. Thanks for listening.